the first of the paper one topic, and also a very fundamental topic for any clinician for that matter. So shock is a pretty much part of everyday clinical assessment of any patient. So much so that any patient before dying, the last thing he would develop would be a shock. So shock is the thing between the life and death of the patient, and it's been evaluated since centuries together, and they have not been able to come up with a proper definition of the shock. So one of the earliest definition of shock was the rude unhinges of the machinery of the life, right? So the machinery of the life suddenly stopped functioning. So that was described, and that was accepted for a long term. But now, because of the advancement in the diagnostic aids and the molecular studies, so we are able to define it at the cell level, right? So basically, what shock means is shock is a state of low tissue perfusion, which is inadequate for cellular respiration. So ultimately, all of that boils down to cellular respiration, where the cells utilize glucose as a substrate and oxygen for the oxidation of the glucose to produce ATP. And everything in the body functions depending upon the level of the ATP. If ATP is there, there is life. No ATP, no life. So basically, we are defining the shock at the cellular level. So it is a state of low tissue perfusion, which is inadequate for cellular respiration. So, what happens in shock? What is the pathophysiology? We'll discuss about the causes of this shock later, but as of now, assume that shock has already developed, meaning the person is already in a state of low tissue perfusion. It is so low that the oxygen is not being able to be delivered to the cells. So when there is no oxygen, but the cells still have some glucose which is available within the cell, which is stored inside the cell. So normally when glucose is there and oxygen is there, cells undergo this aerobic respiration and produce ATPs. The number of ATPs produced by aerobic respiration will be around 30 or 32. So when oxygen is not there, when there is lack of oxygen, the cells switch to anaerobic respiration. Because the glucose still available, the cells switch to anaerobic respiration. When they switch to anaerobic respiration, they ferment this glucose. Because there is no oxygen, they ferment this glucose and the glucose is converted to lactic acid. By this anaerobic respiration, the number of ATP is far less. It is around 2 to 2 ATPs only. But yet, somehow the cell survives out of these 2 ATPs. But as a byproduct of this anaerobic respiration, lactic acid is produced. Now, as the lactic acid accumulation keeps on increasing in the body, that leads to acidosis. Now, acidosis is a risk factor for variety of further pathophysiological mechanisms. But one of the things that acidosis causes is coagulopathy. Now, imagine the patient had a blood loss, and because of the blood loss, patient went into the shock. Shock led the patient to respire anaerobically, to metabolize anaerobically, and that produced acidosis. But acidosis is in turn causing coagulopathy. So when this causes coagulopathy, there is further blood loss, and this further blood loss will actually lead to shock, and this cycle keeps on happening. So acidosis plays a very important role in the development of the pathophysiology of the shock. So this is one, we'll discuss about this later again. So now, as long as the glucose is present within the cell, these cells try to ferment this glucose and convert it into the lactic acid. But over a period of time, the cells also exhaust glucose because whatever is in the cell, it has been utilized, and there is no supply of the glucose because of low tissue perfusion. So once they exhaust glucose, then there is no source of energy for the cell either to respire aerobically or to ferment it anaerobically, and that is where the ATPs are lost. ATP are not produced anymore. When these ATPs are not produced anymore, that will eventually lead to failure of sodium potassium pump. So one of the most important pump on the membrane of a cell or of the organelle is the sodium potassium pump. So this pump pushes out three sodium inside in exchange for one potassium inside. So essentially maintains the water level inside the cell. So whenever, because of any reason, the sodium potassium pump fails, that causes the cell to swell because the sodium is not excreted out. Sodium remains inside. Along with sodium, water also remains inside, and the cell swells. When the cell swells beyond the expected size, that will cause the release of lysosomal enzymes. When these lysosomal enzymes are released, these lysosomal enzymes cause lysis of cell. When the cell is destroyed, all the intracellular substances will be eventually released into the interstitial space. And from the interstitial space, they eventually enter into the bloodstream, especially potassium. So that is the reason for hyperkalemia in case of a shock, right? So this is because one of the reason from the cell, most likely from the muscle cell, because muscle cells are the most underperfused cells and they contain a lot of potassium. So when the cell lyses, they release all of this potassium into the interstitial space, which eventually enters the bloodstream. This entire thing is called as sick cell syndrome. The cell is sick. So sick cell syndrome is when the tissue perfusion is so low that the sodium potassium pumps fail, as a result of which the cell swells so much so that the lysosomal enzymes get activated, cause the lysis of cell, and release all the intracellular substances, especially the potassium, into the bloodstream. Now, this is first phase of the shock, where it affects the cells. Now, as we know that human body is made up of the organ system, which are in turn made up of tissues that are made up of cells. So once this is the one cell that is lysed, similarly, there is reduced perfusion to multiple cells in the body. So when all these cells, multiple cells get lysed, they will activate the immune system. Now, this immune system is also activated from the acidosis. Remember, this acidosis was resulted from the inadequate perfusion only. Now, this acidosis, one of the thing it causes is coagulopathy. The second thing it causes is the activation of the immune system. And one more most important factor that causes the activation of immune system is hypothermia. Now, to maintain the normal body temperature, the production of the heat from the muscle is very important. But whenever there is a shock, there is redistribution of the blood flow. So the blood from the muscle, from the skin, from the splanchnic circulation will be diverted towards the liver, brain, and kidneys. So when this happens, now the muscle becomes underperfused. It sacrifices itself so that adequate blood is sent to the brain, liver, and kidney. So when the muscle is underperfused, it cannot generate heat. So one of the cause for hypothermia is underperfusion of muscle. So an underperfused muscle cannot generate heat. So this is one of the causes that causes hypothermia. Second is when the as the shock progresses, the patient goes into hypotension. We resuscitate the patient with crystalloids. So crystalloids are the first choice of the fluid that we use in a shock when the patient is going towards the hypotension. So when we use these crystalloids, the crystalloids are stored either at room temperature or at below the room temperature, and that is less than the body temperature, obviously. So these crystalloids also cause hypothermia. Remember, the crystalloids, most of the crystalloids are again acidic in nature. So resuscitation with fluids also causes hypothermia, also causes acidosis. And the third thing is if the shock was because of sequestration in the bowel, right? Because of bowel obstruction, and before taking up the patient for laparotomy, if the patient was not adequately resuscitated, so once you open the bowel, once you open the laparotomy, once you do laparotomy, once you open the peritoneal cavity, now the exposed surface of the body to the atmosphere gets multiplied by 100 to 400 times, because all that 4 meter of the bowel is exposed to the atmosphere, and entire peritoneum gets exposed to the atmosphere, from which the heat is lost. So opening up of the cavities. So these are the three things where the underperfused muscle cannot generate heat, or the crystalloids that we use for resuscitation, most of them are cold. or not at least at the body temperature, and opening up of the cavities will also lead to the hypothermia. So this hypothermia together with acidosis and the cell lysis, so these three important factors, these activate the immune system. So whenever there is activation of the immune system, where does it go? So this is the cell which got lysed, and the cell is close to a capillary. Capillary is lined by a endothelium, and between the capillary and the cell is the interstitial space, right? Now this cell is lysed, so all the immune system cells have to come to this site. So they have to come through the capillary. Now they destroy these capillaries. They destroy the capillaries at the endothelium. Once they destroy the capillaries at the endothelium, once there is a destruction, that will further activate the immune system. Now, further activation of the immune system causes further capillary damage. So this cycle keeps on repeating. So when enough number of capillaries are damaged, that will lead to the increased vascular permeability. So because there was an endothelium here and the capillaries got destroyed, the capillaries get destroyed, the tight junctions between them also get destroyed. So all the fluid will seep out into the interstitial space. So if this is a capillary and this is capillary, the cell is surrounded by the capillaries. So all of the fluid gets seeped into the interstitial fluid. So because of the increased vascular permeability, there is increased seepage of fluid in interstitial space. Interstitial space is the space which is surrounding the cell. Because there's a lot of fluid there, that will produce tissue edema. Now, when there is tissue edema, this tissue edema will compress the capillaries. And whatever little blood flow was there, that is also cut off now. This will further reduce perfusion. When further perfusion is reduced, the same cycle comes back. Then it goes back to step one. That is, cells switch to anaerobic respiration. So this cycle keeps on happening. So this second part, what I told is a microvascular changes. So the first one was the cellular change. The second one is microvascular changes. And when this keeps on happening, that will finally result in the changes in the systemic circulation. So what happens in CVS is that we'll discuss this again later. It is just a brief overview. So basically, there is a reduced perfusion. There is reduced intravascular volume. So when there is reduced intravascular volume, the BP will fall and the baroreceptors get activated. They increase the heart rate. In CNS, the patient will have altered mental status because there is less perfusion to the brain eventually. And in the respiratory system, because there is acidosis, in an attempt to compensate that, they need to wash out the carbon dioxide. That is why the respiratory rate increases. The minute volume increases so that carbon dioxide is washed out. And carbon dioxide, when it washes out satisfactorily, that causes compensatory respiratory alkalosis. So the metabolic acidosis was compensated by washout of the carbon dioxide. That is why it leads to compensatory respiratory alkalosis. Then in the renal system, as the blood pressure reduces, this reduces the renal perfusion pressure. The renal perfusion pressure directly correlates with glomerular filtration rate. So the GFR reduces. When GFR reduces, obviously the patients will have oliguria. Also, this will activate the renin-angiotensin aldosterone system, which tries to compensate.
Sir, can't hear, sir.
Hello, 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 hello,
Sir.
hello, hello.
Hello, sir. Yes, sir.
Uh, are you able to hear now?
Yes, sir.
Video is fine.
Yes, sir.
Uh, So, You are okay till the previous slide, right?
Can you
Yes,
start
sir.
from renal?
Uh, so this the previous one is okay, right? The microvascular changes.
Fine.
So in the renal system, as the BP reduces, the renal perfusion reduces. So when the renal perfusion reduces, obviously it correlates with the glomerular filtration rate, which reduces, that leads to oliguria. Then it also activates the renin-angiotensin aldosterone system that tries to compensate. We'll all discuss this again in the compensatory mechanisms. So these are the systemic changes that happen. So this is about the pathophysiology of shock. So where it starts at cellular level, progresses to microvascular level, and finally progresses to systemic level. Right? Is this clear? Hello.
Yes, sir.
So next is levels of shock. So the ATLS describes the shock to happen in three levels. So initially what happens? The heart pumps the blood through the aorta, which eventually enters into the arteries. And these arteries eventually become capillaries. And it is at the capillaries where the cell perfusion happens. Then the blood is drained through the venules, which eventually lead to veins that lead to superior vena cava or the inferior vena cava, and finally the blood goes back to the heart. So for the tissue perfusion to reduce, the block can happen at any level. So the first block, if it is at the heart, so either the heart has failed, which is intrinsic pump failure. The heart has failed to pump the blood because there is a myocardial infarction, right? Or there is a hypertrophic obstructive cardiomyopathy. So this is intrinsic pump failure where the heart is not able to pump the blood that has led to the shock. Or this is called as cardiogenic shock, which is from the heart. Or the preload to the heart is not well because the heart can pump the blood adequately when it can receive the blood adequately. So, for any reason, if the heart is not receiving the blood adequately, meaning the heart is not able to expand adequately so that it receives the blood, meaning there is restriction to the expansion of the heart. Now, this happens if there is a cardiac tamponade. So, when there's a lot of fluid getting collected in and around the heart cannot expand. So, it remains contracted. There is no preload, there is no venous refilling. So, the heart cannot pump blood. So, either it is a cardiac tamponade or one of the major supply for the heart is from the lungs. If the lungs get collapsed, so if there is a tension pneumothorax, the lungs are collapsed, the capillaries in the lungs are collapsed, and the blood cannot come to the heart. Then also heart cannot pump any blood further. So that is tension pneumothorax. So these are obstruction to the filling of the heart. That is why they are classified under obstructive shock, right? So this is the level one shock, where the shock is at the level of the heart. Either the heart is not able to pump or the heart is not able to receive the proper amount of blood to pump. So the cardiogenic shock and the obstructive shock come under level one shock. And at the level two shock, it is at the level of the arteries in the blood vessels or at the level of veins where there is reduced intravascular volume. So reduced intravascular volume is nothing but a hypovolemic shock. So hypovolemic shock is a level 2 shock. And level 3 is what occurs at the capillaries, where the heart is receiving blood properly. There is no obstruction. The heart is able to pump the blood properly. There is no problem with the intrinsic pump of the heart. And the blood is given to the capillaries properly. But at the capillaries, the blood is lost. The blood is not staying within the capillary. This happens when the permeability of the blood vessel increases so that the blood is not staying in the capillary but it is distributed. So this becomes a distributive shock, which is a level 3 shock. So distributive shock can happen if there is a lot of vasodilation, right? For anything, for blood to stay within the blood vessel, if the blood has to stay here, there are two components. One is a hydrostatic pressure, second is colloid oncotic pressure. Hydrostatic pressure is the pressure which is exerted by the blood volume, blood column onto the blood vessel wall. It always tries to push the blood outside. For example, if there is a venous obstruction here and there is a capillary behind, because there is a obstruction here, the column of blood exerts more pressure here. There is a raised hydrostatic pressure, and this pushes the fluid outside. Fluid comes and deposits outside the blood vessel, leading to edema. So this is the cause for edema in a DVT patient because of the raised hydrostatic pressure, which always tries to push the blood outside. There's also one more pressure called as oncotic pressure, which is because of the hemoglobin and the presence of the proteins inside, which tries to draw the blood inside. So even if this is less, proteins are reduced, colloid oncotic pressure is reduced, all the fluid will go outside. So distributive shock happens if there is a vasodilation. Obviously, there is increased hydrostatic pressure because more blood flows, there is more pressure. So distributive shock can happen if there is either vasodilation or increased vascular permeability. Now, increased vascular permeability happens when there is a damage to the capillary endothelium. The damage to the capillary endothelium happens in case of a septic shock or in case of an anaphylactic shock. But the vasodilation happens in case of a neurogenic shock or a spinal shock. Both are same. So these are the only types of shocks which are recognized by the ATLS. There are three levels of shock. One is at the level of the heart, one is at the level of the arteries and veins, one at the level of the capillaries. Those at the level of heart can be a cardiogenic shock or it can be an obstructive shock. And that at the level of arteries is a hypovolemic shock. And that at the level of the capillaries is a distributive shock. So when you tell about the types of shock, according to ATLS, there are only four types of shock. One is obstructive shock, which includes cardiac tamponade and tension pneumothorax. Second is cardiogenic shock. Third is hypovolemic shock, and fourth is distributive shock. The neurogenic shock, the anaphylactic shock, and the septic shock are parts of this. Along with that, people also add endocrine shock, right? But it is not included as a separate entity in a ATLS guidance, which is basically based on the trauma, right? Of which the most common shock is hypovolemic shock. So when hypovolemic shock happens, and this hypovolemia somehow becomes a part of any of the shock that is described, right? So that is why it is most common type of the shock. Now, hypovolemia essentially means that there is less volume in the blood. So either it is the blood that is lost or it is the water in the blood that is lost. So based on that, it can be a hemorrhagic shock or it can be non-hemorrhagic shock. So if it is non-hemorrhagic shock, meaning the volume is lost, the water is lost. So either it is because there is reduced intake, right? So if the patient has any tumors of the stomach or in the esophagus where the patient is not able to take adequate water, so either reduced intake of the water can cause, or there is increased loss of the water. The patient has incapacitating vomiting. The patient is suffering from severe diarrhea, so there is loss of water, or there is sequestration of the fluid. There's lot of fluid in the body, but this fluid is not in the blood vessel. The example may be a bowel obstruction, right? So intestinal secretions are up to 8 liters per day. Now the blood volume is 5 liters. So up to 8 liters per day is secreted in the intestine, but most of it gets absorbed or it is let out of the body. Now when there is an obstruction, because there is a mucosal edema, because there is an obstruction, this fluid is not let out of the body. And because there is mucosal edema, it is not absorbed also. So all these secretions remain in the sorry, all these secretions remain in the bowel, not in the blood vessel. So that is called as sequestration. So non-hemorrhagic shock can be either because of reduced intake or because of increased loss or because of the sequestration of the fluid. Now, when it comes to hemorrhagic shock, this hemorrhagic shock, there are various methods of classifying this hemorrhagic shock. So, the first one would be a revealed hemorrhage and a concealed hemorrhage. So, revealed hemorrhage means, sorry, so it can be a revealed hemorrhage or a concealed hemorrhage. Revealed hemorrhage is you are seeing the blood. So it is called as hemorrhagic shock is called as blood on the floor and four more. So this is a aphorism, blood on the floor and four more, right? So revealed hemorrhage is actually the blood on the floor. So the patient is coming to you with hemorrhage from a cut vessel, from an artery or from a vein. So the patient is coming from a vessel which is cut and you are seeing that it is spilling blood onto the floor. That is one. Or there is an open fracture with a vascular injury, right? Which is grade 3 in Andrologusto classification. So there is an open fracture with a vascular injury, or there is a hemorrhage from the vessel, or the patient is coughing of blood, lot of blood. So hemoptysis, or is vomiting blood, hematemesis, or there is hematochezia. So these are all the areas where you can see that there is a bleeding from any surface. Now, concealed hemorrhage is where you don't know, where you cannot see where the bleeding is happening. The patient is going into the shock, but you cannot see that bleeding. So it can be either a traumatic bleeding. So this is where the four more comes. So it can be in the head, in the skull, it can be in the chest where there is hemothorax, it can be in the abdomen, which is intraperitoneum or a retroperitoneal bleed, or it can be a long bone fracture. Almost 500 to 1.5 liter of blood can be lost in a tibial fracture, and 1 to 2 liters of blood can be lost in the femur fracture. So, long bone fracture, which is closed. So, there is only compartment syndrome, the limb is swollen, the pulses are not palpable, but you are not seeing any blood outside. So, this is trauma. But sometimes spontaneous concealed bleed can also happen. So, spontaneous concealed bleed can happen if the patient has an aneurysmal rupture in the brain, or there is abdominal apoplexy. Abdominal apoplexy is a spontaneous bleed into the abdominal cavity is called as abdominal apoplexy, or the patient is having occult GI bleed. He is keeping on losing blood slowly. So these are all the types of the hemorrhagic shock. It can be non-hemorrhagic, sorry, hypovolemic shock, non-hemorrhagic or hemorrhagic. So non-hemorrhagic is either less intake, more loss or sequestration outside the blood vessel. Hemorrhagic may be revealed or concealed. So revealed may be from a blood vessel which is cut, or there's an open fracture, hematemesis, hemoptysis, and hematochezia. Concealed, where it can be traumatic, either in the head, where it is EDH or STH, or in the chest, or in the abdomen or the retroperitoneum, or a long bone fracture which is closed fracture, or it can be a spontaneous bleed. So this is one way of classifying a hemorrhagic shock. Right? Is this clear? Hello.
Yes, sir. Yes, sir.
So the other way of classifying this hemorrhagic shock is a surgical and non-surgical shock. It does not refer to the etiology of the shock, but basically the management of the shock. Now, surgical hemorrhage is an hemorrhage which can be controlled by surgical means. For example, you see an artery which is cut, you can ligate the artery or you can reanastomose the artery. So you see there is a hemothorax, you put a ICD drain. So if there is a bleed from the in the EDH or STH, you drain them. So all these are the maneuvers by which you can surgically control the hemorrhage. So, or if, for example, there's a splenic bleed, you remove splenectomy, you are controlling them. But non-surgical bleed is bleed from the raw surfaces and the mucosal membranes, which cannot be controlled surgically. Right? Only thing you can do is you can pack it with adrenaline soaked gauze pieces. But apart from that, you cannot do anything because either it is because of coagulopathy. Most of the times it is because of the coagulopathy where you cannot manage them surgically. or it can be because of radiation mucositis, right? So all those bleeds which cannot be managed surgically, they are called as non-surgical hemorrhage. All those which can be managed surgically are called as surgical hemorrhage. Right? It is not the etiology but the management. Now the another way of classifying this hemorrhagic shock is a primary hemorrhage, reactionary hemorrhage, and a secondary hemorrhage. Right? Primary hemorrhage is the bleed on table. You are operating a patient and a vessel is cut and it bleeds on table. It is called as a primary hemorrhage. Or it is the hemorrhage happening at the time of trauma. So that is primary hemorrhage. Reactionary hemorrhage is the hemorrhage which is not happening on table but within 24 hours. Now, this is because either the clot has dislodged. For example, there was a bleeding from a blood vessel, and this blood vessel formed a clot, and this clot had stopped the bleeding. But you resuscitated the patient. When you resuscitated, the blood flow increases. Till now, the blood vessel was constricted. You resuscitated, the normal BP of the patient became normal, the blood flow increased, and this increased blood flow has dislodged this clot. So, one of the reasons for dislodgement of the clot is resuscitation of the patient. Right? Second is vasodilation. Right? So, the clot is dislodged either by the increased blood flow or because of the vasodilation and normalization of the BP, the clot gets dislodged. The second is slippage of ligature. So either that you have tied the ligature very loosely or that you have tied it properly because there was lot of edema. After 6 to 8 hours, when the edema reduces slightly, the diameter of uh, the vessel that you had ligated reduces because the edema is reduced and the knot becomes loose and it slips off. So reactionary hemorrhage is the hemorrhage which occurs within 24 hours of the surgery or the trauma. It is either because of the dislodgement of the clot or because of the slippage of ligature. Now, secondary hemorrhage is the hemorrhage which happens in the second week, so which is from the 7 to 14 days. Now, this happens because of erosion of the blood vessel wall. Most commonly, it is because of sepsis, infection, which erodes the blood vessel and leads to the secondary hemorrhage, right? Especially, if, for example, if a thin flap, the inguinal lymph node dissection has been done, and the femoral artery is exposed. The femoral arteries, there is no flap cover over the femoral artery. Now, this gets infected. That will cause the erosion of the blood vessel and cause the bloat of the femoral artery. Similarly, if extensive neck dissection is done and the carotid artery is exposed, sternocleidomastoid cover has not been put, again, it will lead to the erosion of the carotid artery if there is an infection. So, sepsis will erode the blood vessel and cause bleeding, which usually takes place in the second week, or it can be because of the malignancy that is putting pressure, right? Or inguinal lymph node, which was not excision biopsy was done, but later again some of the lymph node was remaining that put pressure and that was the erosion, or it can be because of the pressure. Right? Most commonly it is because of the sepsis, but it can also occur because of malignancy or the pressure. So this is primary, reactionary, secondary. They are mainly with respect to surgery, but can also be applied to the trauma. And there is a little difference between the bleeding from artery and a bleed from vein in the development of shock. See, when the artery bleeds, it is a spurt which is rapid and there is no vein in the artery. So, earlier fall in BP will be observed. Because you recognize the fall in BP earlier, you send for investigations earlier. Now, when this happens, at the earliest point, even though there is fall in BP, the entire pathophysiology has not yet taken place and the cells are still having adequate oxygen. So therefore, because the investigations are sent earlier, because it is recognized earlier, because the bleed is rapid and spurting, the blood investigations initially may be normal. At the time of sending an investigation, the blood investigations, especially the lactic acid and base deficit, will be normal. So it means that in an arterial bleed, at the time of hypotension, still some amount of cellular respiration is maintained. This is first. Second is, whenever there is an arterial bleed, artery has been blessed with good media. So there is good amount of smooth muscle in the tunica media. This will cause vasospasm and result in halting of the blood. So the body can itself stop the bleed because of vasospasm in the artery because it has got good smooth muscle coverage. Now, if there is a vessel which is transacted like this, and if there is a vessel which is just lacerated on one side, transacted is both the ends are cut off completely, and on the other side it is just lacerated. A vessel is lacerated like this. Can anybody tell me the vasospasm, the stopping of bleed will be better in a transacted blood vessel or a lacerated blood vessel?
Transacted.
Why?
Bleeding is more in lacerated artery.
Why?
So the vasoconstriction causes more opening of the lacerated
Uh,
artery.
so, yes, that is right. So, whenever this happens, the muscle here gets contracted and it stops the bleed here. And the muscle here gets contracted and it stops the bleed here. But when the muscle here it gets contracted, because there is no bridge here, this gap just keeps on widening and the bleed in the transacted blood vessel stops faster than in the lacerated blood vessel. But when it comes to venous bleed, first thing is that because there is no smooth muscle, it is difficult to spontaneously control the venous bleed. Second, the venous bleed is a ooze and it is a slow ooze. So when the blood keeps on oozing slowly, the body has time for compensation of BP. So blood pressure can be compensated and for long period of time, BP remains normal. And by the time it manifests as reduced BP, already much of blood will be lost, right? Because it is taking, because there is long time and it is slowly compensating, the blood loss is happening. Here you can recognize it early. So at the time of recognition, at the time of hypotension, the amount of blood loss is lesser only. But here, because it is going on for a long period of time, by the time you recognize hypotension in a venous bleed, much of the blood will be lost. And this compensation is happening because of the redistribution. The blood from the skin, skeletal muscle, and splanchnic circulation is being diverted to the intravascular volume so that the volume remains normal. So, as a result of which, the cells at that area already are suffering from hypoxia. And that is why in a venous bleed, if there is a hypotension, at the time of hypotension, you get these levels. Obviously, lactic acid will be elevated and base deficit will be higher. Right? So the point is that an arterial bleed recognized at the time of hypotension, the cellular respiration is still maintained. But in a venous bleed, by the time hypotension is recognized, the cellular respiration is already gone. Right? Is this clear? Hello.
Yes, yes.
Then classes of shock according to ATLS. Now, ATLS classifies this shock into type 1, type 2, type 3, and a type 4 shock. Right? It is more of a grading of shock. So, it is all dependent upon the blood lost. The blood, about 15% of the blood is lost, up to 15% of blood lost in type 1, type 2, 15 to 30%, 3 is 30 to 40%, and 4 is more than 40%. The normal volume of the blood in an adult is expected to be 70 ml per kg, while in a child it is expected to be 80 ml per kg. This is the normal volume of blood that is expected in an adult and a child. So in adult, it comes to around 5 liters. So if you take 15% of the 5 liter, so it will be around 15 5 is 75, 750 ml. Right? So this will be somewhere between 750 ml to 1.5 liter. This is 1.5 to 2 liters, and this is 2 liters, more than 2 liters of blood is lost. So when the blood is lost, earlier when BP was not there, people used to rely on pulse rate. So the pulse rate is less than 100 here. It is maintained. Here it becomes more than 100. Here it becomes more than 120. And here it becomes more than 140. Remember, in certain animals, when there is blood loss, there is drop in BP. When there is drop in BP, reflexively the heart rate should increase. But in certain animal experiments, it is found out that when there is a drop in the blood pressure, there is simultaneous drop in the heart rate. So that the number of times the heart beats per minute is reduced, so that the number of times, if there is a bleeding vessel here, the number of times the blood comes to this vessel is reduced. As a result, this is one of the mechanism where, because there is less blood coming to this blood vessel, there is less blood loss. So this is one of the coping mechanism where the animals develop bradycardia in shock, so that the amount of blood to that bleeding blood vessel is reduced and it stops bleeding. But that is not the case in humans. In humans, because of reflex activity, tachycardia happens. But there is something called as relative bradycardia. So relative bradycardia is defined as a heart rate of less than 100 when the systolic BP is less than 90 mmHg. So when the systolic BP falls to less than 90 mmHg, you are expected an heart rate of more than 100. But the heart rate still remaining less than 100 when the systolic BP falls to less than 90 mmHg is considered to be a relative bradycardia. And it is found that in the patients where the systolic BP is less than 90 mmHg, if the heart rate is maintained between 60 and 90, these people have a better survival advantage than those where it is maintained more than 90. Less than 62, it is abnormal. Less than 60, 50, 40. So it means the patient is going into the cardiac failure also. So in any patient, if the relative bradycardia has been established, it means that the body is responding better and they have better survival advantage over the patients where the heart rate has become more than 90. So this is what they used to see before the BP was there. Next, the systolic BP is not reduced until more than 1.5 liters of blood is lost, right? So this will be normal here, this will be normal here, and it is reduced here. Now, once you talk about systolic BP, you need to talk about pulse pressure, which is essentially the difference between the systolic BP and the diastolic BP, right? Here, there are not much of compensatory mechanism because 750 ml, you don't need so much of compensatory mechanism, so the pulse pressure will be normal. But here, what happens is systolic BP is normal, but because of the activation of the sympathetic nervous system, the diastolic BP reduces, right? Sorry, it increases because the sympathetic system gets activated. There is vasoconstriction. So because of vasoconstriction, this remains normal. This increases. As a result, pulse pressure narrows down. So pulse pressure falls here. Now, the cause for falling of pulse pressure in a class 2 shock is because of rise of diastolic BP. But here what happens? There is eventually a fall in the diastolic BP, but the systolic BP further falls. So as a result, pulse pressure falls. Here also pulse pressure falls, right? So the cause of fall in pulse pressure here is further fall in systolic BP, while the cause for fall in pulse pressure here is increase in the diastolic blood pressure. So this is the difference between class 1 and class 2 shock, where pulse pressure is maintained in class 1, but it is narrowed down in class 2. Then respiratory rate. So here, obviously, it will be normal. Now, as the class of shock increases, the cellular perfusion reduces. So, anaerobic respiration increases, more lactic acid, more carbon dioxide, more respiratory rate. So, it will come anywhere between 20 to 30. So, it can be 30 to 40. Here it is more than 35. All those systemic things that we discussed, they come here. So, then CNS. Here the patient is a little anxious. Here also patient is slightly anxious. Here the patient becomes irritable, and here the patient is lethargic. So this is the CNS response to shock. Then urine output. Here, obviously, it will be maintained, which is at least 30 ml per hour. And next is here it will be reduced, but maybe around 25 ml per hour. Here it comes to 15 ml per hour, and here it is almost negligible. Now, these are the features on which the ATLS classifies the shock as class 1, 2, 3, 4. But remember, out of all these features, pulse rate, systolic BP, pulse pressure, respiratory rate, CNS, urine output, the most good indicator bedside is a systolic BP. And yet, this cannot be, any single of these parameters cannot be taken as a direct indicator of shock. For example, pulse rate, I told you, various patients have various responses. So some patients, even if they have shock 3, class 3 shock, their heart rate is still maintained to less than 100 because of relative bradycardia. Some patients in shock 2 can have, in class 2 shock, can have more than 100. So pulse rate alone is not a reliable indicator. And when it comes to systolic BP, it is all about the compensatory mechanisms of the body. So in a pediatric age group, even if there is a loss of lot of amount of blood, they can compensate it well, and they do not show the signs of hypotension until it is very late. But meaning a class 2 shock will have only the features of class 1. A class 3 shock will have only the features of class 2. A class 4 will have only the features of class 3. But in case of a geriatric patient, in old patient, even a small amount of blood loss cannot be compensated by the body. And if they are in class 1 shock, they show the features of class 2 or class 3. So SBP can also be not taken as an independent factor. So they thought that maybe urine output is a good indicator, right? Because it tells us about the perfusion of the kidney. But remember, you think that a patient came to you who was in shock, the urine output was reduced, and you gave him fluids, and the urine output become more than 30 ml per hour. At this point, you think that the patient has come out of the shock because his urine output is maintained, and you stop resuscitating. What happens is a hypoxic injury, which is also called as hypoperfusion syndrome. Now, when you resuscitate the patient, the urine output is increased only means that the kidney is well perfused. That's all. Because what is happening, already the blood from the skin, subcutaneous tissue, and the muscle and splanchnic circulation is diverted to the liver, brain, and kidney. And already there is compensation from those. Apart that you give fluid, it only means that the renal perfusion is improved. But at this point, still the muscle is underperfused. In such conditions, if you stop giving fluids, you think that patient is stabilized and patient does not need fluids anymore, then those things continue to be in hypoperfusion, and that produces hypoperfusion injury. That is called as hypoperfusion syndrome. So none of these considered individually are a good indicators for a shock. So that is why they developed something called as shock index. So the shock index is a little better indicator compared to heart rate and blood pressure alone. So shock index is basically heart rate divided by the blood pressure. But this used to take only the systemic blood pressure into consideration. That is why we have modified shock index, which is called as MSI. So MSI is heart rate divided by mean arterial pressure. So this mean arterial pressure is actually the systolic blood pressure plus one third of the pulse pressure, right? So or you can also write it as systolic blood pressure plus one third of diastolic blood pressure minus, sorry, systolic blood pressure minus a diastolic blood pressure. So this is a better indicator. And if there is low MSI, it means that there is a increased mean arterial pressure. So it is a hyperdynamic circulation. If there is high MSI, there is low MAP, it is a hypodynamic circulation, right? So that is why MSI is now considered hemodynamic stability indicator. So it is better than these considered individually. So this is considered as hemodynamic stability indicator. So this is one more index for the shock. One more is lactate levels, right? As I told you, because the glucose cannot be oxidized. The glucose is converted into lactic acid by fermentation. So the more lactic acid you get, it means that the more is the the less is the oxygen supply. So indirectly, it is a measure of again hypoxia. So the lactic acid normally should be zero point 0.5 to 1 millimole. So if it becomes 2 to 4, it is called as hyperlactemia. Hyperlactatemia. Now this lactic acid becomes more than 4, that is associated with acidosis, that is called as lactic acidosis. Right? Hyperlactatemia is not associated with lactic acidosis, but when it reaches 4, it is associated with lactic acidosis and it is considered to be significant. Now, along with that, you also need to understand base deficit. As I told you, because there is lactic acidosis, the pH of the blood falls. So the pH has to be maintained between 7.35 to 7.45. If you take the mid-range value to be 7.4, no, the pH has fallen to 7.35. You correct this pH to 7.4 by giving a base, right? Because it is acidic, you need to give a base. So the number of millimoles of base that is required to correct pH of 1 liter of blood to 7.4 is called as base deficit, right? So it is the number of millimoles of base which is required to correct pH of 1 liter of blood to 7.4. It can range anywhere between -2 to +2 millimoles or milliequivalent per liter. If it is more than 8, now it is considered to be associated with 25% of mortality, right? But if the patient has acute kidney injury, more than 6 is also considered to be associated with increased mortality. So these are all the indicators of a shock, or you can also call them as endpoints for resuscitation, which we'll discuss again later. So the last topic for today would be compensatory mechanisms of shock. Is this clear till now? Hello.
Yes, sir.
Yes.
So how does this shock get compensated? So once there is shock, the first thing that happens is stimulation of sympathetic nervous system. Now, how this happens is shock is basically reduced intravascular volume, and reduced volume means reduced pressure. So when there is reduced pressure, because it is the pressure which is exerted by the column of blood onto the blood vessel. So if volume is reduced, obviously pressure is reduced. This is sensed by the baroreceptors, which are present in the atrium itself, or in the aortic arch, or at the carotid body. So these sense that and they activate the sympathetic nervous system. Along with this, these also stimulate the supraoptic nucleus and the paraventricular nucleus. So these are the nuclei in the brain, which is supraoptic nucleus and a paraventricular nucleus, which will stimulate the release of ADH, antidiuretic hormone, from the pituitary. And this ADH will absorb free water. So it will reduce the water that is lost so as to maintain the intravascular volume. See, blood is lost. Along with that, lot of water is also lost. But blood cannot be recovered by the body. So what it does is it tries to conserve water as much as possible. So ADH absorbs free water, meaning not associated with sodium, just free water it absorbs, which is released from anterior pituitary, stimulated by the supraoptic nucleus and the paraventricular nucleus, which in turn are stimulated by the carotid body. Now, once this activates the sympathetic nervous system, so what it does is it will act on the cardiac muscle and it will act on the smooth muscle of the vessels. On the smooth muscle of the vessel, it causes vasoconstriction. Vasoconstriction increases the diastolic blood pressure. Also, acts on the cardiac muscle, and this increases the heart rate and increases the cardiac contractility, which increases the stroke volume, which in turn increases the systolic blood pressure and tries to compensate. So this is by the activation of the sympathetic nervous system. And the second thing, when this reduced volume reaches the kidney and reaches the juxtaglomerular apparatus, the cells of the juxtaglomerular apparatus sense this, they release the renin. So this is second. They release renin. Now renin activates angiotensin 1. This angiotensin 1, so renin basically converts angiotensinogen to angiotensin 1. So this angiotensin 1 is converted into angiotensin 2 by angiotensin converting enzyme, which is actually present in the endothelial cells of the pulmonary capillaries. Now this angiotensin 2 is first, it stimulates ADH secretion so that it will absorb water. Right. Second, angiotensin 2 itself is a powerful vasoconstrictor. So the vasoconstriction capacity of the angiotensin 2 is 8 times more than that of the noradrenaline. So that is 2. And the third is it acts on the adrenal cortex and on the adrenal medulla. Fourth is it itself can cause sodium plus water retention by acting on renal tubular cells. Right? So the angiotensin itself can activate the release of ADH. It is a powerful vasoconstrictor, almost 8 times stronger than the noradrenaline. So it can cause the activation of renal tubules and conserve sodium and water. It can act on the medulla and release norepinephrine, epinephrine, and dopamine, which all lead to activation of the sympathetic system. And that increases systolic and diastolic BP. In the cortex, it acts on zona glomerulosa and zona fasciculata. So glomerulosa will release aldosterone. Aldosterone will cause sodium reabsorption. Along with that, water also comes inside. So which helps to increase the volume of the blood. So sympathetic system tries to cause vasoconstriction and increase the blood supply by causing increased contraction of the heart, while this adrenal system, it tries to conserve retain the fluids, and zona fasciculata will cause release of cortisol. That is why in stress always the glucose levels are increased, whatever be the type of the stress, because of the release of the cortisol. And this is fasciculata which causes release of cortisol that maintains fluid equilibrium. This is second mechanism. And the third mechanism is the release of ADH from the supraoptic nucleus, right? Release of ADH. And the fourth is at cellular level. So at cellular level, what happens is all the body is trying to do is to maintain the fluid within the cell. So this is a capillary, and this is a cell. This is interstitium. Now the fluid has to remain in here. So this has a pre-capillary sphincter and a post-capillary sphincter. It causes the contraction of pre-capillary sphincter more and not so much of post-capillary sphincter, meaning the inflow is reduced, but the outflow is maintained from the capillary. So when less inflow is there and more outflow is there, the blood volume here reduces. So when the blood volume here reduces, the hydrostatic pressure reduces. When the hydrostatic pressure reduces, all the fluid from the cell will be put to interstitium. From the interstitium, it will be put to the vessel, and that is why the BP will be maintained. right? It needs to maintain the intravascular volume by taking fluid from the interstitium. To take that, it needs to reduce its own hydrostatic pressure. So that is why there is a selective vasoconstriction of the pre-capillary sphincter more than the post-capillary sphincter, so that the inflow is reduced but the outflow is maintained, so that the blood volume at a given capillary is reduced, which further reduces the hydrostatic pressure, which pulls all the fluid from the interstitium, which in turn pulls the fluid from the cell. So by this mechanism, the intravascular volume is maintained, which maintains the urine output. But what is happening? Cell is left dehydrated. So that is why if you take urine output only as a end point of resuscitation, the cell keeps on being dehydrated, because these are all the compensatory mechanisms that are happening. So these are the four compensatory mechanisms. But the flow of the sympathetic system and the hormones, they are all not infinite. Sometimes they stop. When they stop, that leads to decompensated shock, which further leads to a state of irreversible shock, which is a topic for tomorrow. With this, I just want to tell introduction to the triad of death. So, because we are talking about trauma, the hemorrhagic shock. So, when there is a trauma and there is blood loss, approximately 25% of these patients, within minutes of the blood loss, if there is a significant blood loss causing class 3 or class 4 shock, within minutes of this blood loss, these patients develop platelet dysfunction. They develop hyperfibrinolysis, and they develop low fibrinogen levels because of some issue, some genetic issue. Within 25% of these patients, within minutes of trauma, they develop platelet dysfunction, hyperfibrinolysis, and low fibrinogen levels. And when this happens, this is called as acute traumatic coagulopathy. So this is acute traumatic coagulopathy. So when this acute traumatic when this acute traumatic coagulopathy happens, if you do not transfuse these patients with blood, blood is lost. But if you try to give these patients fluids, then the fluids dilute the coagulation cascade. Whatever it is, already it is into coagulopathy, but whatever the coagulative factors are there, that gets diluted, and this further adds to the blood loss. So this is called as trauma-induced coagulopathy. So trauma-induced coagulopathy is acute traumatic coagulopathy plus dilutional coagulopathy. Till now, what we have discussed is a coagulopathy and hypothermia and acidosis to be the features of a shock, where hypothermia can lead to acidosis, acidosis can lead to coagulopathy, and hypothermia can also directly lead to coagulopathy. This is called as lethal triad of death, death triad of death. Right. So once the patient enters into this lethal triad of death, it is very difficult to break this cycle. Right. So we'll discuss about this lethal triad of death tomorrow.